All right, so today we're going to show positioning for our upper GI series. In another video, we have changing instructions and history taking, so I'm going to skip all of that. Just know that when we do any fluoral procedures, typically we confirm with the patient that they followed their prep before we start, even though we have to do a scout image for that as well. So Mariah is going to be my patient. I am going to bring her in the room after I get it set up, so I'll be with her in 1 second. And then this is going to be, so with an upper GI, the first image we would do is a scout image, which basically allows us to see inside the patient and make sure that everything that needs to be clear is. So if they followed their prep, then their NPO for at least 8 hours prior, meaning that their stomach would be empty. So somebody left an image receptor in here, which is not a huge deal because we're just pretending, so we'll leave that in. Mariah is a sthenic patient, so to get her scout of her abdomen, I would likely do a T-shot on her. One lengthwise to capture pubic symphysis, and then a crosswise image to just capture the diaphragm. So with that, we need to be in D10. We're at a 40-inch, well, we were at a 40-inch SID, so that is lit up on there. I am leaving this out of the way for a moment just till I get my patient on the table. So I'm going to lower this a little bit and let her get on the table, and then we'll reconfigure after that. Okay, so come on in here. In the other video, she would already be changed. She would have on a gown. You can go ahead and have a seat on there, and then lie back on the back. She would have a gown on, open to the back, and then she would not have on a top, no bra. Probably her underwear could stay on as long as there was no snaps, buttons, middle, or zipper, anything to obscure. If there was none of that, then she could leave her underwear on for this exam. So we'll bring her table back up. It'll stop automatically at a 40-inch SID. And then we could go beyond that, but for my height, that is perfectly fine. So we will align the tube with the image receptor. Push that in. We are in D10, but we'll just make sure, because if we're in D10 and aligned, it means that our tube and our image receptor are on top of one another. All right, and we have a 14 by 17 in there currently lengthwise. So that is set to a 14 by 17 lengthwise. Anytime you put a patient on the table, you want to make sure that they're straight. You don't have to keep your feet like that. All right, so we are going to center midline, which means my finger's on her xiphoid and the CR is coming down the middle. And then I just need to include pubic symphysis on this. So pubic symphysis, greater trochanter is here, which means I need light field to include that. And the light is slightly deceptive because you can see the light looks like it ends here, but the image receptor is down here. So I feel like I might bring her a little this way. Push that back in. Good. Just like that. And I am going to use left marker in the bottom left corner of the light field. And then I'm going to give her breathing instructions. So for these images, what I'm going to have you do is take in a breath and then blow it out and hold it out. Okay? I'll let you know when. I'm going to come back and set the control panel, which I should have probably already done just to save time, because anytime you can cut steps and make it quicker, it's always ideal. So I'm choosing for the scout abdomen, I'm going to go 80 kVp at 10 mass. 80 kVp, 10 mass, large focal spot, 40-inch SID. So then I'm looking through, watching my patient, and I would tell her, go and take in a deep breath, blow it all out, Good, hold it out, don't breathe. Beep, good, you can breathe and relax. Then I'm gonna come in and I am going to mark my spot of overlap with my marker. And I'm gonna change my collimation to 14 by 17 crosswise. I'm gonna change my image receptor to be crosswise. And then I'm going to move the table to include the overlapped portion, which I know with her body like this, I absolutely have diaphragm on there. I could collimate from side to side because I don't need all of that. And then I put my marker back on her left side. Now, it probably appears like that's going to be an anatomy, but remember this is overlapped area. So on the first image, the radiologist could see that. So it's not really a big deal that it's on here for this image. Since shielding is not something that's practiced so much here anymore, at least in the state of Florida, we are not going to shield. If protocol where you work is shielding, then yes, we could definitely shield on this image. The first image, because of where the gonads lie, we would not shield. So we're just not going to shield on this. So when I tell you again, we're gonna breathe the same way, okay? Go ahead, take in a deep breath. Blow it all out. Good, hold it out, don't breathe, deep. Good, you can breathe and relax. At this point, I would go check those images and make sure that the scout images came out and clear those with the radiologist or the lead tech, whoever had the authority to clear those. I would come back in, and at that point, our fluoro would start. What that would entail would be setting the control panel for fluoroscopy. There would be a footboard attached to this table. I would have the patient step off the table. The table would go 90 degrees upright with the footboard attached. I would then put the patient up, standing on the chessboard with her back against the table in a slight LPO. I would hand her a cup of barium in her left hand. And then when the radiologist came in, after introductions and them talking, they would have her drink, and then they would fluoro and take images as she's drinking. They usually have the patient turn around in different directions and take spot images of them drinking to capture the anatomy. At some point, the table will go back to this horizontal position. When that's happening, I usually try to keep a hand on the patient and help them as they're going back to recognize that they're not going to fall, that we're right here. We usually give the patient a pillow at that point too. And then the radiologist would take more images with her rolling around. And then once the radiologist was done with all of the images they needed, they would leave the room. At that point, the patient would get no more barium, but I would take what are called our overhead images or our post-fluoral images. So I'm gonna go ahead and do that. And this positioning is specific to a sthenic patient. So we're gonna be, it's a 14 by 17 for this, sorry. First image, I thought it blinded you. This first one is a 14 by 17 lengthwise, and I did switch my image receptor to 14 by 17 lengthwise. This one is open so that you can capture any barium that is still in the esophagus and in the fundus portion of the stomach. So central ray on this is midway between the xiphoid and the lower lateral border of the ribs. So that to me is kind of confusing. So usually what I tell students is you put your middle finger on the xiphoid, you take your other middle finger and you find the very bottom portion where the ribs start to wrap around. You put your middle finger there, and then you lay your fingers down in the shape of a W. And where my thumbs touch, I'm gonna make my central ray right there. Just like that. So again, xiphoid, lower border of the ribs, W, just like that. And then I'm going to use my left marker again in the very left bottom corner. If this was a gown, I would do this same thing so that the marker would be demonstrated, because if you don't do that, the marker is not going to be visible. It would just image like that. All right, so left marker, just like that. We're gonna do the same kind of breathing. It's in and then out and hold it out, okay? Okay. All right, so technique on this, because she would have barium, the techniques change on the overheads, and we're gonna go 110 kVp because she has the barium in there, which is very radiopaque. And we're gonna do 110 at 2 mass. Okay, 110 at 2. So go ahead for me, take in a deep breath. Blow it all out. Good, hold it out, don't breathe. Beep, good, you can breathe and relax. And get this oblique sponge here. And now what we'll do, now what we're gonna do is the LPO, that was the AP, upper GI. All the rest of the images are collimated to 10 by 12 lengthwise. So I'm going to change my collimation to 10 by 12, and I'm not going to open it after this image. Take my marker. And before I roll her, because if I just roll her like this, I know she's going to be way too far onto that side of the table. So before I do that, I'm going to have her come towards me a little bit. Good. Shoulders. Good. A little more. And you try to keep your patient in line so that when they roll evenly. We're gonna bring your right arm over to your left shoulder. Bend this right knee for me. Good. Now, what you don't want is them to shift their hips when they roll. So typically you keep your hand on them and tell her just roll like a log. Good. Lean back against that. Straighten this leg out. Good. And with this, I usually tell you guys to watch shoulder and hips, and you make sure that your hands are in the same plane. Roll up a little bit. There you go. Good. All right, so shoulder, hips, same plane. And if you look at her from the top, she's in a nice straight line this way, and her body is angled in a 45-degree oblique. Meaning if you measured from her back to the table, this should be a 45-degree angle. Okay. The centering on this is the same as before. It's midway between the xiphoid and the lower border. Can you just bend this arm of the ribs? So I'm going to find lower border of the ribs with my middle finger, xiphoid, and where my thumbs meet. Okay. Now, most of the time, what happens is that students forget that the stomach is on the left, so this is much easier to reach, and they start to position over here, but the stomach is not on the right. Unless she has situs inversus, the stomach is on the left. So, we're gonna put that in the white field since we have it, and not on the patient, and we're gonna do the same kind of breathing. This is the LPO. Overhead for the upper GI. So go ahead, Mariah, take in a nice deep breath for me. Blow it all out. Good, hold it out, deep. You can breathe. The technique did not change on that. It won't change actually until the lateral. Take my marker off, and then I'm gonna have the patient go ahead and roll onto your stomach for me. Good. Bring your right arm down by your side. And then come towards me just a little bit. Good. And roll up on this. And lay down on that. You can just bring this one up by you. Good. All right. So same thing I want in this. You want hip and shoulder in the same plane, meaning you don't want their shoulders too far up or their hips. Just a little bit. I'm gonna take this out a smidge. Okay. And then same thing, you want this nice and straight, and she's in a 45-degree oblique. The central ray on this is an RAO, right anterior oblique. The central ray on this is midway, let's see, it's 1 to 2 inches above the lower border of the ribs. So her ribs are right here, and I want 1 to 2 inches above that. So my 3 fingers is 2 inches. So I want somewhere probably on the middle finger would be probably 1.5. So above the lower border of the ribs, 1 to 2 inches, and then midway between the spine and the lateral border of the abdomen. So halfway between my hands. Midway between spine and lateral border of the abdomen, 1 to 2 inches above the lower border of the ribs. Now, with the patient PA like this, you have to remember this is left side. The way the stomach is going to go with the barium in there, it's going to pull it down. So I'm going to put marker placement here. I don't want marker here because what can happen is it'll project onto the other side of the spine and make it look like that's the left side, and that's not what I want. So I'm going to leave her just like that, still 10 by 12, same technique, and then same breathing. Go ahead, take in a deep breath for me. Blow it all out. Hold it out. Deep. Good. You can breathe. I'm going to change the technique for the lateral. We're going to go to 4 mass, which kind of makes sense if you think that, oh, surprise. We're probably, I'll probably go 3.8. My options are 3.8, 4.2. I feel like with her body habitus, 3.8 would be sufficient. And the reason for that is that we don't have the MA station capability to get 4 exactly. So when you're between that, you kind of have to decide, do I need a little bit more based on the patient body habitus, or would 3.8 be sufficient? And I feel like 3.8 would be sufficient. All right, now what we're gonna do is I'm gonna take this out and have you roll up on your side so you're facing me. Okay. Good, scoot your hips towards me a little. There we go. Knees and ankles on top. Just arms like you're gonna go to sleep. Pray. Now the biggest thing before I even start with a central ray is to make sure that her back is straight. So you wanna put your hand on their spine and kind of palpate and make sure that her spine is straight all the way down. Her hips aren't rotated, her shoulders aren't rotated, because it's not comfortable and patients start to kind of roll forward. So she has excellent posture. Thank you. You're welcome. Still on a 10 by 12. And then what this one is, this line is at the border of the ribs. At the bottom of the ribs, not border. So at the bottom of the ribs, and then this line is 1 to 1.5 anterior from mid-coronal. So my thumbs would be on mid-coronal right now, and I want to bring this line 1 to 1.5 inches in front of my thumb. So at the bottom of the ribs, 1 to 1.5 anterior to mid-coronal. Because in this view, what the stomach is going to do is drop and the barium is going to pull this way. So the patient is in a right lateral, so I need to use the right marker, and I usually stick right marker up because I know the stomach is going to be pulled down. The technique on this was double, so we're at 110 at 3.8 technically, and the breathing is the same. We'll go ahead, take in a deep breath. Roll it all out. Hold it out. Deep. Good. You can breathe and relax. At this point, I would go ahead and go look at all of the images that I took and make sure that all my overheads were sufficient and that nothing needed to be repeated. If that was the case, then I would come back in, move all of this out of her way, because you never want this stay in the way so that the patient has the potential to injure themselves. So I'm going to move the table a little bit before I get you up. kind of center the table a little bit and bring it so that she's not gonna hit anything there. And I'm gonna lower it a little bit. And then I'm gonna give my patient some post instructions before I let her go get dressed. So I'm gonna let you sit up. Just kind of swing your feet off to the side there. Good. And what I would tell her is, you've had quite a bit of barium today. The only way that we get that out is to flush it out. So what we're gonna have you do over the next day or two, it totally depends on you, you're gonna wanna drink 8 to 10 glasses of water on top of what you normally drink. So coffee, tea, whatever you wanna drink is fine. You just wanna add 8 to 10 glasses. What that'll do, your kidneys don't really have to work hard to filter the water, so it kind of flushes everything out, keeps it hydrated, your intestines, and what's going to happen when you start to have a bowel movement, it's going to be white from the barium. Once your stool returns to normal color, you don't have to keep up that increase in water intake. You can, it's not going to hurt you, but you definitely don't have to. But we just want to make sure we get all of that barium out. Okay. I'm going to bring you back and let you get dressed, and your doctor will probably get these results within 24 to 48 hours. Do you have any questions? Okay, well let's walk you back and get you dressed.